Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Hello, everyone. We have a great episode because we have Viraj Vora, the endodontist. You know him from Instagram at Viraj Endo. I met him on Instagram and I couldn't believe the phenomenal work he did. Not only does he do great endos, but he does these awesome like MODBL, subgingival restorations. He's well known for his endo and restorative. You should call yourself like the tooth saver, Viraj. And Viraj is great because he's the best. He like reached out to me to speak to our club, which he gave a fantastic presentation last year. And then he also reached out, he's like, I want to help. And I'm like, Viraj, we need your help. So that's what this episode's about. Viraj, welcome to the pod.
Thank you. Thanks, Sanj. Nice to see you again. So just the kind of things I wanted to go over, and this is mainly because, being an endodontist, I obviously get cases from you guys, and the cases are obviously pre-screened before they come to me, and then there's obviously like an evaluation to be done depending on the type of cases. They can either be first time round, they can either be retreats or potential surgeries. So I just wanted to backtrack a little bit because I remember the days when I was a general practitioner, starting out and also starting out with endo and just some of the challenges that I faced. And I know that some of the students, when they graduate school, they probably face the same challenges. So I just wanted to break down into different kind of steps for what the kind of challenges you could face. And just basically, things like assessing your skill set, knowing when is the best time to refer, if it's complicated diagnoses that you can't figure out, which just leads to more efficiency in your practice. Because if you can't figure it out, especially if you've been seasoned enough to do quite a bit of endo, it's going to give the endodontist some type of trouble as well. So the first thing is diagnosis. I think this is just the main function of what you are going to do with your patient. And diagnosis is something that sometimes we kind of overlook in terms of, we think we know the problem, what the patient has, but it might not be that. And sometimes that might lead to unnecessary treatments, potentially wrong treatments as well at the same time. And that can just lead to like further complications. So the first thing that, this took me a while to learn as well, was obtaining relevant history. Now we hear that in school the whole time, make sure you get good medical history, dental history, but sometimes I think we take it with a cavalier approach in terms of we don't really ponder too much into what patients are actually saying to us. And what we really want to do is also try to replicate some of the symptoms that the patient has in our own office. So, the first thing is obviously communicating with the patient. Things like, when did the pain occur? Did you have any recent dental work done as well? And sometimes, for the most part, patients don't really even remember, but we can get a fair idea just by looking in their mouth as a general observation. If you see lots of dentistry done, you see lots of restoratives, you see general poor hygiene, you can kind of work out that, this patient probably has either a high caries index, they may have poor attitudes towards oral health as well. And at the same time, they just might not know just how to clean their teeth. We know many people that just do a once over with their toothbrush and think that that's it. Some other patients that also come in as well, they may not actually have any kind of like heavy dentistry, but then when you dwell into their history, and especially if they give non-specific symptoms, you might be thinking of things like cracks. So we need to dwell a little bit deeper and find out in terms of, well, what do they do? Do they have any inherent baseline characteristics? Meaning, do they have any nervous habits? Are they grinders? Are they clenchers? Anything in their diets as well? Especially if you, ponder into like Asian diets as well, where they may eat a lot of nuts and things like that. That might also add to the individual baseline characteristics as well at the same time. And then also,
Can I stop you there,
yeah.
Viraj? Because I eat a lot of nuts.
I
So
do.
what is the number one cause of cracked teeth? Like, what is it that the patients are saying they're eating?
So I don't think so. We need to work on the language because whenever we say cause, we always think that A plus B equals C. but that's incorrect because we have to say things are associated. So for example, I wouldn't expect the 23-year-old to have multiple cracks in their teeth and needing endo in that way. But I may expect like the 60 or 70-year-old to come in with non-specific symptoms and potentially have cracked teeth. So what I mean by that is, see, so there's an acute episode of crack. So meaning that person that bit down on the olive nut on the weekend and maybe they heard a crack or something like that. That patient presents to your office, perhaps maybe the next day or the day after. Then you have chronic cracks. Now, chronic cracks are like a function of life, pretty much. You've got two hard objects pounding at each other for X amount of time. And also dentistry itself has a role to play. The more we drill on teeth and the more tooth surfaces you lose, they get weaker. And then obviously chomping on that, you initiate cracks. So we can think that, cracks as such, they are prevalent in society, but individual baseline characteristics might elevate that risk. And especially as well, if you have patients that have lost multiple teeth as well, and let's just say they only have a couple of molars on one side, on the other side is missing, well, they're preferring that side. And if you combine that with the fact that, that they may have grinding habits, parts of their diet, things like that, that could potentially increase the incidence of cracks, that might lead you to some clues to why they are presenting in the chair. Cracked teeth, for the most part, in the early diagnoses, in the early stages, is very difficult to diagnose sometimes because patients have a tough time saying which tooth it is. And in the mouth, there's a lot of referred pain as well, meaning that, they may think it's the tooth in front, but it's the tooth behind. It could even be referred to the top. One way to look at this problem is to look at the general population and look at what is the prevalence of cracks out there and which teeth have the highest prevalence as well. So for the most part, we're looking at least the lower molars, so the first and second molars. The second molar specifically as well, and especially if you see a patient that has, let's just say, a shallow restoration or no restorations as well, and you've got to kind of scratch your head at that point thinking, well, we know for the most part that teeth go south because of multiple restorations, caries, deep restorations. So when you have one that doesn't have any restorations or very minimal, we've got to ask ourselves, well, how did this tooth die? Because teeth don't just die because they're bored one day. They die because there's some type of insult that's going on. Now, I had a patient that I saw on Wednesday, and she's got a lower 3.6 and a 3.7. The 6 has got very large restorations, and when I get her to bite on the tooth sleuth, it's positive on the mesiolingual cusp, and the 7 has also got a distal marginal fracture. But when I vitality test them, they're both the same. It might be that the 6 has an exaggerated response, but the issue here is that this is what we call subclinical pain. She can feel it inside, but I can't replicate in any of that with testing. So I'm gambling now with the fact that, well, is it the 6 or the 7? So sometimes in cases like that, when we have diagnoses that we cannot, when we have symptoms that we can't get like a proper diagnosis for, unfortunately, the best thing we can do is just a function of time, just to wait it out.
Yeah, I totally agree. Just wait. Don't do the endo on the wrong tooth.
No, no, and for the most part, obviously, see, on one hand, the patients don't want to wait it out because they're in pain. But on
Yes.
the other hand, you kind of have to explain to them, you know what, that we don't want to do a root canal on the wrong tooth, because even doing a root canal itself, no matter how good you are at it, there's always an inherent risk of doing the procedure itself,
Yeah.
especially if the risk outweighs the benefit because you got the wrong tooth. And
Mm,
unfortunately here, because we're paying for all our treatments, and especially when you send it
yeah.
to the service as well, the patients could be just spending so much on their treatments. And unfortunately, what that might lead to is one of the teeth being extracted because they simply can't afford the root canal, but it could be the wrong tooth as well. So
Oh.
what I'm trying to say is, don't be afraid to sometimes, if you cannot get an accurate diagnosis, to tell the patient, we're going to wait it out, perhaps manage them pharmacologically,
Mm,
especially with things like NSAIDs, which are anti-inflammatories, and don't be afraid to do a referral as well at the same time. Because if you're
good.
having a tough time, it's not like the endodontist is going to have a much easier time either.
Yeah.
Now, for the most part, sometimes as well, have I been in the situation where the patient's in so much pain where they're like, doc, just open the one that you think is the one.
Mm-hmm.
Obviously, here this comes to like informed consent as well, but you have to
Okay.
write down, you have to put in your notes as well in terms of this is what I think, the patient's in so much pain, and this is what we decide
Mm-hmm.
to do. And again, you could go back in terms of just looking at what is the most likely tooth that is going to be cracked in society as well, especially if you're dealing with lower molars as well at the same time.
Yes.
And especially, when you see teeth as well, and I'm talking the opposite of no dentistry, we see a lot of dentistry on a tooth, where you see a full
Hmm.
5-surface resin that's, very old, breaking down. It hasn't really got recurrent caries, but all the tooth, the cusps are all thinned out. And, you can see cracks on either the buccal or the lingual surfaces as well. The chance that that is the tooth in question is pretty high. But again,
Okay.
you need to add up all the information. So you can't just
Mm.
go with just the fact, well, I think it's that, or just, tap on it a couple of times and the patient says, yeah, that hurts. Because sometimes some of the issues that I have found, especially with patients that have got like poor oral hygiene, is that gingival issues can mimic root canal
Hmm.
pain of endodontic origin, but it's not that. And I see this sometimes on patients that I've done root canals on, and they come back for a follow-up. And they say, Doc, you know what? Sometimes I get some weird feelings on the tooth and it just hurts sometimes. And when you probe around the tooth, you get a lot of bleeding upon probing as well. And then,
Mm.
especially when they've got deep crown margins, or they may have an open crown margin where they're collecting a lot of plaque in the interface area, and that's just inflaming the gum. And remember, the gum is attached to the tooth. So we need to differentiate between that, because that could potentially lead to what we call false positives, meaning, you could potentially class this tooth as disease when it's actually healthy and either redo the procedure or submit to a root
Mm.
canal when it was something else. So these are some of the ones where, we have to be careful in terms of what we are actually looking at and how we're diagnosing it, so we just don't lead to overtreatment. One of the good things about teeth, or bad things you could say in such a way, is that it doesn't affect mortality. So, worst
Yes.
case scenario, you lose the tooth, but the patient doesn't die. But again, we don't want
Hmm.
a patient to lose any tooth, because,
Yes.
we're obviously here to save teeth as well at the same time. The other thing as well is looking at pain of non-odontogenic origin as well, especially when you have teeth that have got open pulp chambers. And when you test them, they test normal, meaning, you put the cold test on it and you get a normal response. There's no secondary caries or primary caries. Restorations are fairly shallow, but the patient is in a lot of pain and you just cannot figure out what to do. In those cases, I would say that an immediate referral is just advised, because
Okay.
I've seen many cases where, they've had a root canal done, say like on the 7, on the 6, and then
Hmm.
5, and then finally the patient's sent. And then we find at that point, you know what, we might be looking at something completely different here. And this could be things like, it could be TMJ pain, it could be
Mm.
just general poor occlusal schemes as well at the same time. We might be going into things like, trigeminal neuralgia, et
Mm.
cetera, like that. But these are really, really important. So, patient history, and then using your tests to see how far are you from agreeing with what the patient says, and then estimating from that, what do you think the likely outcome would be? So in terms of, everything that we do in our office, no matter what it is, the patient always wants to know, Doc, how long is this going to last? And
Mm.
all we can do is just prognosticate. But we can only prognosticate with the information we have at hand. If we don't have all the information and we don't do adequate history testing, dentists are actually very poor at prognosticating. And the patient really wants to know what is the outcome. The difference is that on one hand, you'll be giving a prediction, but the outcome is the event. So meaning they have to live the tale to know if that event comes true. So,
So do you give like a number of years or percentage of
yeah.
success?
So again, this is like a function of really trying to understand your work beyond the technical aspect, meaning you have to try to follow up. Now, there's a lot of patients in dentistry that are lost to follow up, especially like with things like endo. And the also
Hmm.
thing is, when do you follow up? So, for example, endodontists get very excited when they do a root canal and they see the 1-year follow up that is healing. Then the patient's
Yeah.
lost forever.
Yes.
So
Yeah.
what they're going to do is they're going to rely on that 1 year as the sole factor to what they did and how it healed off. And we're estimating that this is what it's going to be like for the rest of their lives. However, in year
Hmm.
2, the tooth can be extracted. And it could be extracted simply because of the fact it broke. And
Yes.
you will never know the difference. So one of the poor things about outcomes is that the evidence is only as good as when you observe it. That's the thing.
True.
So for the most part, the outcomes for caries-related root canals is pretty good, especially
Mm.
if we can change patient attitudes towards oral healthcare afterwards. Meaning,
Mhm.
we've got to see why they came in. They came in because, you know, they've got poor oral hygiene, lots of heavy dentistry. If we can change some of these things and their attitudes, potentially they may not come in with that frequent problems in the future. However, when we have things like trauma or cracked teeth, the problem is that there's an uncontrollable variable already. That's the crack.
Mhm.
And we can do the root canal for symptoms just like as we do with caries, but we need to then see in terms of, well, how long is this tooth going to last because it's got a crack? We can't fix the crack. We can't drill it out. We can't glue it up. We look at things like, where is it? How deep is it? And what's the extension to estimate how long this tooth will last? And ultimately, if you want to know how long it lasts, you got to do the follow-ups as time moves on. But again, take that with a grain of salt, because let's just say in a year, you know, I treat 500 cases, and out of that 200 are cracked. But out of the 200, I only see 10% of them back.
Yeah.
The sample is useless. And I see them back for a 1 year follow-up, right? And then after that, I lose 50% of those cases in the 2 year follow-up. Then
Mm.
out of those, I lose another 50. So meaning by the time I get to the 5 or 6 year recall, I have a handful of cases from the entire cases of cracked teeth I treated 5 years ago. So
Mm.
when we think numerically, it actually becomes more discerning to us that we don't really see a lot of our cases back. But at the same time, we've promised ourselves, or even promised to the patient, that from the prognostic standpoint, this tooth is going to last a lifetime to you, or X amount of years. That's the thing. So this is one of the things that we face in endo, and especially when we look at our research studies as well. You know, everybody looks at research studies in terms of, okay, it's done in university, it's done in a controlled environment,
Mm.
it must be good. But the study ended the year after. So meaning, you know,
Oh.
in endo, you know, we've got a famous study that was done in the 90s, and it was done in Scandinavia, and it was just looking at in terms of, you know, the kind of processes we do for doing the root canals. You know, you rubber dam isolate, you know, you irrigate, you open to a certain file size, et cetera, like that. Then in the following year, they've lost X amount of their cases for the recall, and then the study
Mm.
finished. We're using that same study in 2024 to justify a 95% success rate. What you should
Wow.
really ask yourselves is that, where are the patients today? And also,
Yes.
where are the patients that you didn't see for the recall? Because there's some
Yes.
information there that we just don't know. That's the thing. So
Okay.
just saying that, you know, we need to have a little bit of humility in terms of how we
Hmm.
communicate to our patients. And
Okay.
I can tell you, you know, it's patients really appreciate when you say to them, I really don't know, but if you keep coming back for follow-ups, then we can both get educated in terms of how this is
Yeah.
doing. That's the thing.
Good.
So, you know, just like what I said, once we start to think numbers wise, it's a completely different story to what we were originally trained in school to do the technical procedure of the work. That's the thing.
Raj, you mentioned diagnostics. What are you doing for diagnostics? Are you using EndoIce? Are you
Yeah,
using frozen
yeah. So
souls?
so I'm using the same thing that you guys are using as well.
Okay.
But again, there's nothing special what the endodontist does. It's more so, again, you got to listen to the patient. If the patient is saying
Okay.
things like, you know, my tooth hurts to air, I can't drink cold on that side whatsoever.
Yes.
Every time I ice cream, it hurts. It gives me pain along the side, a headache. Before
Yes.
you do any kind of testing whatsoever, this is what we call the prior probability. You've
Okay.
already got in your mind, you're thinking, you know what, it's likely a vital tooth, it's likely inflamed, they're getting referred pain as
Mm.
well, it's likely
Okay.
irritable pulpitis. So what I'm saying, you've built like an estimate to what you think it
Yeah.
is
Okay.
already. Then afterwards, you do the examination of the patient, and you know, you do
Okay.
your testing. This is what we call the likelihood. And
Okay.
then afterwards, you're going to then use that information to see, well, if I treat them, what is the likely outcome of this case then afterwards? So
Okay.
this is where I go back to, obtaining relevant history just by talking to the patient. Uh,
Mm-hmm.
there's a lot of information that we can get from just talking to the patient at first, which is what we don't tend to do, versus us just jumping in and saying, you know what, this is what I think is, this is what I think, which for the most part, for any kind of seasoned dentist, you're probably right. But looking or just asking the patient beforehand just clears away so much of any kind of dilemma that you know exactly what kind of test to do. So for example, the main test is the cold test. But the thing is, remember, if you use a cold test on a tooth that's got open pulp chambers, um,
Mm-hmm.
you are very likely to get a response. But if you have an open pulp chamber and you put the cold on and you don't get a response, now you're scratching your head thinking, oh my God, what's going on? I would have thought it'd be vital. The
Mm-hmm.
other issue on the other end of the spectrum is that you've got a calcified tooth completely, patients complaining of pain. You put cold on it, they don't feel it. Immediately, you're going to think it's necrotic. But the thing is, you've got to think in one aspect as well. Prior, okay, maybe the cold can't transmit through the tooth because it's completely calcified. Maybe I haven't got my pellet cold enough. And also at the same time, maybe it's not that. Because now you're going to do radiography, you don't see any kind of periapical lesions. You might go one step further and do a CBCT, and now you still don't see nothing. Now you're scratching your head again and thinking, what's going
Mm-hmm.
on? So these kind of situations, when it's something that you don't expect, the last thing
Mm-hmm.
you want to do is open up a tooth.
Okay. That's
So
great. Like to address the chief complaint, you have to listen to the chief complaint.
you
Yeah.
you
So
have
that's
to.
great.
Have to. And like William Osler, I mean, he said way back in the day that you have to listen to your patient because your patient is telling you the diagnosis.
Yeah, exactly.
Yeah,
It's true.
yeah.
And you mentioned CBCT. Like, do general dentists need CBCTs and microscopes and ultrasonics in order to do?
Can you say that again? You're kind of cutting up.
Oh, sorry. Do general dentists need to do CBCT, have ultrasonics, use microscopes in order to do diagnosis?
So I think that for any dentist who's got a solid interest in doing root canals or just seeing more or having the tools that can help them much better with diagnostics, regardless if it's endodontics or implantology, I think that they shoid explore those horizons of implementing those kind of things into their practice, especially the microscope. The microscope, for example, I mean, it came out in the mid 90s, especially towards endo. And as time has moved on, like it's pretty much, I would say, mandatory for all endodontists, especially the younger guys going into grad school to be trained on microscopes. But I think that, as time has moved on, I mean, we see many of our European partners as well using it for general restorative dentistry as well. Periodontists are using them as well. And it just helps you see more. And the more you see, the better you can treat it, especially when you're doing restoratives like, deep class twos, to see where the band just fits that gingival box. And, you don't have any leakage coming through, just so that you can accurately place your resin, is priceless. But one of the downfalls of this is that because in dental school, you're not trained from the microscope off the get-go, if you buy it tomorrow, you're going to find a hell of a hard time to use it because on the microscope, everything's done indirect. Now we're taught in school, to work on the upper teeth indirectly, but not the lower teeth. But you can't use a microscope with direct vision at all. So not just for endodontics, but you can't even do it for restorative dentistry. So the biggest challenge is purchasing the microscope and using the mirror in the lower jaw to do your work because everything's backwards. Yeah, but again, it's one of those things that you've got to practice and practice. And for any dentist just bringing this into their practice on day one, they're going to find it frustrating. Patients will get frustrated because, they're going to be, why is this taking so long? I remember actually when I was in residency and the first year when we had to do everything on the microscope, like our program director would make sure that you're using it. Root canal take me like 4 hours because I would drill a little bit and then I would look on the side. Okay, well, did I drill straight? Okay, good. All right, now let me go back in like that. But again, it's just like with any tool, the more you use it, the more proficient you become. Now, CBCT as well for endodontics, two things. Number one, it can help with planning, meaning planning for things like, if you're planning your access on difficult teeth, either rotated teeth or, the calcified teeth, surgical planning as well. So in terms of if you're doing apicoectomies, you know exactly where to cut, and you can look at, different dimensions like in the sagittal view as well, which you won't see on two-dimensional radiography, so you can know how much to cut. So to help you with the technical procedure, priceless. On the flip side, using CBCT and endodontics to verify that you've got a periapical lesion could be overkill, because we know that the sensitivity of CBCT is extremely high, meaning if you're not going to see something in two-dimensional radiography, you are going to see in 3D. But the question comes now is that what are you going to use with that information, and how is that going to help the patient? I talk specifically about retreats or a root canal that was just done. So for example, let's just say that, a root canal was done within the last year, but the patient is having non-specific pain in that area. And then it's sent to me, and then I take an x-ray, and on the two-dimensional looks fine, but then I take a CBCT, I notice a little bit of widening at the end of the root. Now, for somebody that would seem like, okay, well, this is a disease and of endodontic origin, and we need to go ahead and treat. But the patient's completely asymptomatic. We can't replicate any kind of symptoms. So now we have to ask ourselves, are we going to treat the CBCT or are we going to treat the patient? Because the CBCT is always going to find any kind of minor radiographic findings because it's just highly sensitive. And the other way we've got to look at this problem again is that we need to see what is the prevalence of periapical disease in the society with root canals. And when we look at those numbers again, it's very high. You're looking at it from 30 to 50%. So meaning, if you, for example, let's just say this week, you screen new patients and you take a Panorex, you're going to see on the Panorex, patients have X amount of root canals. You're going to see lesions somewhere. And that's not what they've come in for, because they just want to have a new dentist, but you took it as a screening x-ray. What you'll notice is that for the most part with root canals, you're going to see lesions all over the place. So meaning the disease is very prevalent. So we need to change our mindset in terms of we've got a procedure that works for the most part. We can't really fix x-rays on every single patient. So maybe we need to lower our threshold and kind of accept disease and work towards patient outcomes. So for example, again, that patient that came in, they've got a little finding on the mesial root, but they're not in pain. The tooth is heavily restored. So the question comes now is that if I treat this tooth, I could be the one sending this tooth to the grave just because I'm treating it. But that's what they've come in for. So in fact, we're actually losing teeth. We're not saving teeth.
Yeah, that's a good point.
Yeah, so this is something that we're going to be very careful with CBCT, especially with endodontics when we're evaluating disease. And again, the time frame that they just came a year ago. Like they just had the root canal last. That's the thing. Not to say that it would radically change for like a 10-year root canal, but this is where patient history comes in terms of asking them, okay, when did you get this done? Why did you get it done? And for the most part, patients may not be able to answer, because I get many patients saying, well, I was in pain. But then take a general look in their mouth. If you see heavy dentistry as well at the same time, it's a no-brainer why they got this done in the first place. I've only seen maybe about a handful of 95-year-olds, 98-year-olds that have come into my practice with no dentistry. And what they came in for was a cracked tooth. So what I'm trying to say is that, there's probably some type of link out there in terms of if you take care of your teeth, and you have minimal baseline characteristics in terms of teeth that may have poor occlusion, your diet, etc., like that. Cracks are a function of life, meaning at some point these might show up alone. But obviously, if you combine dentistry with it as well at the same time, cracks may become more prevalent just because of the other things that we're doing in the patient's mouths as well. You've gone silent again.
Sorry. I think that the number one indicator for a successful outcome is case selection.
Oh, for
So
sure.
can you give us some tips on case selection?
For sure. So even with me, like, being an endodontist, I case select. I don't do everything that comes into my practice. And case selection again, it could be something like, can we do something to make this patient better? And is it going to be worthwhile? Not just for them, but also financially as well at the same time. So for example, because I do restorative dentistry, I get people sending me cases thinking that I can restore everything. but that's just not true. I get cases sent where, you're looking at margins at least 3 millimeters all the way down to the gum. So on one hand, technically, I could do it. I could go ahead, I could do deep gingivectomies, and I could do like a 5-surface buildup. I could do a post-in, et cetera, like that. But then when you look at the rest of their mouth, you see that they've got so much other work that needs to be done for teeth that could potentially make it. So the question comes now is that I'm not going to charge you, $2,200, $2,300 for this tooth when you can spread that money to the rest of your teeth in your mouth. So
Yeah.
that case just it doesn't make sense to just do that case, and they are not just spending the root canal fee, but then they have to now put the crown fee as well. And one of the issues that we face in North America is that, let's just say I've treated that patient in January. Well, they're not getting a crown until next year, January, until the
Yes.
so if that tooth breaks in the meantime, even though I've restored it, just because of the fact there's hardly in any tooth structure, well, they're out completely as well at the same time.
Yes.
So, that's one aspect. The other thing is also individually assessing your skill set as well. You have that patient that comes in that's either anxious, they've got a calcified tooth, they can barely open as well at the same time. That's another case selection thing there. Send that off to the endodontist. The endodontist is not happy to do that job anyway. But the thing is, case select as well in terms of do the cases that you think, especially for the new grads that come out of school, that will make you enjoy the procedure. The last thing that you want to do is case select with things saying that, I want to do it because I want to improve my skill set, but I know it's hard. No. Take it step by step by step. I know a lot of GPs that are fantastic with their root canals in terms of, I would prefer that they do it in their practice just because of the fact that they get everything done. But these guys have learned over the years what they can and cannot do, meaning I still work with them. They will send me the harder cases, but the cases that they do themselves, they do it very, very well. In fact, I would say to them, keep those cases in your practice because you do it well. That's the thing. But again, endo's not for everybody. There's been many a times that, some dentists I've worked with within their second year out of school has completely changed in their 10th year. Now they just don't want to deal with those kind of issues with doing, certain types of RCTs. They prefer doing crown and bridge work. They prefer doing implant work as well. So, you have to build your confidence as you go up. And if it's something that you're interested in, like endo, don't be shy to say, sometimes, when the years go on that I want to get a microscope. I want to try. Yeah, absolutely not. I absolutely do it because, there's not that many endodontists for them to keep selling microscopes to. They're going to get more income, these companies, from selling them actually to general practitioners.
Yeah.
But what I'm trying to say is, if you have an interest as well, don't be shy to say, I want to get a microscope. And, I may not do many endos, but at least it can open up a new avenue for me. And perhaps I can also incorporate this into the general dentistry that I do on a daily basis. So, and because these things are just more easily available nowadays, I think that dentists should just take advantage of them as well. And not get frustrated with it as well at the same time. Like, for anybody who's got a sincere desire to learn, they will keep at it the whole time. But there's obviously, certain things within that might not make that possible. I mean, especially for new grads or associate dentists, they're running around especially in the Toronto area, at least between 2, 3, 4 practices.
Yes.
Practical as well at the same time.
Okay.
So I'm talking about the one that, who finally decided to open up their own practice and, they want to, serve their patients in a different way. It's definitely something that they can look into in the future.
Oh, that's great. And Viraj, how about post-operative pain? What should we be prescribing?
So for the most part, if you've got your diagnosis dead on, the post-operative pain should be minimal. And minimal meaning that for the most part, patients can just be managed with just ibuprofen. Ibuprofen meaning that all pain in the mouth is primarily of inflammatory origin. And ibuprofen is the main drug of choice. Some things that you do in the procedure itself may increase post-operative pain. And one of the biggest things in endo is over-instrumentation. Yeah, and especially over-instrumentation when you've got an infected tooth, because you're potentially sending infected material out of the root canal and then the patient is obviously generating an immune response to that. Over instrumentation in terms of also when you're tearing the foramen as well at the same time from its natural dimensions, especially if you've got a curvature and you make it straight. These are obviously, you could be tearing the apical part of the periodontal ligament as well. So patients might complain of post-operative pain after that as well. But for the most part, post-operative pain in endo, I would say maybe about 1 to 2 days. Also remember as well, it's a function of the patient's pain threshold as well. Some patients, for the most part, have got a very high pain threshold, and they may not have any pain afterwards. Some patients, on the other hand, are very low pain threshold as well. So I tell every patient after I'm done the treatment that if you have pain, take the ibuprofen. One of the things with ibuprofen that we need to know is that it's got a very good onset time. Onset 30, 40 minutes, maybe an hour, depending on body weight. One of the bad things about ibuprofen is that its half-life is about 2 to 4 hours. So meaning half the drug's metabolized, and if you add on then 4 half-lives after that, it's gone. So that's why you need to load it in your system. We say every 6 hours. So if you're going to give ibuprofen 600 milligrams every 6 hours. Now, for the normal patient, so no medical histories that could be contribute to for them taking ibuprofen, they can take up to about 3,200 milligrams max per day. Tylenol, you're looking about 4 grams per day. Tylenol is a second drug of choice for patients that cannot take anti-inflammatories, knowing that it will take the edge off, but it won't attack pain at its source, which is of inflammatory origin.
Yes.
I don't see any need in endodontics to give narcotics, codeine, OxyContin.
Okay, good.
I think those are just overprescribed and just simply done because of the fact that the dentist thinks that, let me hit them hard with a codeine, potentially so I could knock them out, and that then could alleviate their pain. But I get many patients coming in who've been prescribed codeine and they've told me it hasn't done anything whatsoever. And then my front staff tell them to switch to ibuprofen, and prior to them coming in for the consult, they're telling us, yes, it works. Lastly, the other thing is antibiotics. They're completely overabused.
Yes.
Do I give antibiotics?
Totally agree.
Oh, yeah. Do I give antibiotics? Sure, I do. But I would give antibiotics for the patient that's got a swelling. They can't open because of a result of that swelling as well. They've been sent to me. I can't get in there to even do anything. So I'd give them antibiotics as an adjunct. Now, I know some dentists as well, what they may do is that they will give the patient an antibiotic simply because of the fact that they want to get their quality of life back prior to them seeing me. Because the likelihood of a patient being referred and them seeing me exactly on the same day is low, especially if they're out of town. And by the time the referral comes or the patient calls and then we can see them, I mean, even though we've got gaps for emergencies as well, some we just may not be able to see. So dentists might give it to him for that. But also there's many times where dentists would give them antibiotics for irreversible pulpitis. So meaning they should have given them ibuprofen, but they're giving them antibiotics and the patient is still in pain. It's hard to believe that a simple over-the-counter medication like ibuprofen can have such benefit, because most of the times we're thinking, oh, the patient has so much pain, we have to give them a prescription.
Yes.
We have to give them antibiotic. But no, just simple over-the-counter non-steroidal can work. Some patients may prefer Aleve. Naproxen just for compliance and scheduling. Like you may just have to give 2 tablets a day. For the compliant one, I usually go straight for ibuprofen. And like I said, it's something that's very cheap, easily available. An Advil brand now, they actually make a single 600 milligram pill. They call it Advil 12-hour, which I think came out maybe around 2019. Versus prior, we always had to give them a script so that the pharmacy can give them a single 600 milligram pill, or they take 3 200s. So that's something new as well nowadays.
You said that you prescribe antibiotics for swelling. Do you do that just for intraoral swelling, extraoral swelling, or both?
If I can get in there and I can drain it, that's the number one thing for me. The main thing, like if they've got like a cellulitis coming out here, and like I said, if I can't get in and do anything, then I may give them an antibiotic and tell them to come back in about a week, just so that, number one, the swellings come down. This help to alleviate some type of discomfort so I can get in there. But the main thing is basically just getting inside. Sometimes you may have to complement with an incision and drainage as well. So for some patients, opening up the tooth, but then also if you have, I would say even an indurated swelling that's not fluctuant, sometimes just, just making a small incision there just relieves the pressure and they can feel much better with that. Obviously, if it's fluctuant and you're just going to get the pus out of there, both through the tooth and through making an incision in the gingival area, that will just help the patient huge. But again, it's knowing when to give them antibiotics as well. Ideally, what we do want to give is a narrow spectrum antibiotic like penicillin, but no one really does that. One of the issues with penicillin is just compliance because the amount of pills you have to take. So we usually resort to amoxicillin, which is more broader spectrum. And, it's pretty safe. The next one that we would probably go to if someone is pen allergic would be clindamycin. Now, clindamycin is great. It's got good bone penetration as well. One of the issues is that with penicillin, especially with the elderly patients, is that it can lead to stomach issues. So either profuse diarrhea because clindamycin wipes out everything. So it wipes out even the good flora in the gut as well. So be careful when you do give that to older patients and just advise them that this is something that could potentially occur.
Great. And lastly, you've seen a lot of cases that have been referred to you by general dentists. What type of errors are we making? And how can you help us?
So it could be all over the place. So I mean,
Okay.
are you talking specifically in terms of the technical work?
Yes, that's great.
Missed canals is probably the main thing. Yeah. As in, if I see in my schedule, an upper 1.6 or 2.6 or lower 3.6 or 4.6, and it was recently done, the likelihood of there being a missed canal is pretty high. And again, this is going back to what I said before about what we call prior probability, knowing the kind of things that generally occur in your practice. So meaning if I see a 2.6 retreat, which for the most part, all cases that have been prior treated are consult only. We rarely ever do a consult and a start on a previous tooth. If it's an upper molar or lower molar, I'm immediately thinking before the patient walks in the operatory that this is a missed canal. And then it's kind of like you have to test yourself. So, because the test can only do so much. What you have to do is interpret the test result. The best thing that you can do is prior to the patient coming in, whatever minimal information you've got, test yourself in your mind and see whether or not is that what it is that's coming in. Because now you're building a model in your brain and you're updating these probabilities every single time a patient comes in. And this is what makes you not just a good diagnostician, a great diagnostician then afterwards. So meaning, I then take the x-ray and you take an off angle and you see straight away, yeah, the likelihood there being a missed MB2. But then to test yourself properly is to go into the case and then after say, yes, I was right, like that. So that's probably the number one thing there. Number two is things like teeth that have got fractures in terms of vertical root fractures as well. Because sometimes dentists are not sure whether, is this something of endodontic origin or is this something of a structural origin? And they're trying to see, if I send it to the endodontist, can they fix this before we start talking about implants? And for the most part, vertical root fractures are not as prevalent as tooth-related fractures. So tooth-related fractures, I'm talking the tooth broke because of the fact that, it's poorly restored or they got recurrent caries and then, a cusp got undermined and they broke it. Meaning the number one reason why root canal treated teeth are lost by far is because they break. But patients will infer that as my root canal didn't work. Most likely the root canal is working because for what you came for initially, that pain's gone. But there's another reason why your tooth is being extracted, meaning the time management from when you do the root canal to when you restore it is probably the most important thing than the volume of irrigant that you use, the type of file that you use as well, the type of gutta perch you use, the type of sealer, which in the whole mass of everything, that's noise. The signal is basically in terms of how quickly can we restore this tooth and put this back into function. And that's not just for patient outcomes, because no patient wants to walk around with a tooth that's broken. But if you also subscribe to the bacteria model, it's a no-brainer. Close the tooth immediately once it's done right there and then. And hence, that's one of the reasons why I chose to do restorative dentistry, is just because of the fact that the timeliness to how you close it, so from a bacterial point of view, but also from a structural point of view, knowing why teeth are lost, it just makes perfect sense.
It does, yeah. And Viraj, does every single root canal treated tooth need to be crowned?
No, not at all. Not at all.
Okay.
Not at all. And the thing is, so this is like a dogma. And we were taught this, in school, that root canals make the tooth brittle, which they don't, or, root canals make the tooth weaker, which they don't for the most part. Now, what I mean by that is, if you're going to be aggressive with your treatments, if you're going to access with a number 8 round burr, and if you're going to prep all the canals to like a 12 taper, yes, you've inherently made the tooth weaker. But remember, causation and correlation are two different things, because sometimes you will still see those cases that were treated way back in the 80s with the Gates Glidden preps, and they're still in the patient's mouths today. But it doesn't take a genius to work out that, the more tooth structure we remove from the tooth, the weaker it is. The other thing is also assessing how many walls does it have after. So for example, let's just say that you have that 22-year-old that unfortunately has got, deep occlusal grooves and a deep occlusal pit, and they got caries through that, and it went in and attacked the mesobuccal pulp point, the tooth died. The rest of the tooth is absolutely fine. All the marginal ridges are intact. They've got good thickness of dentin substrate left over. Do the root canals, just an occlusal access. You've taken out the caries and you just put the resin in, you're done. In those situations, it's now over treatment to go and shave down this tooth to go and put a crown on. However, on the flip side, you see that tooth, the lower second molar, that has a shallow amalgam or no restorations, there's a crack. You can do the smallest access possible. It can look super cute on an x-ray. You can show all your friends. You get so many likes. You haven't addressed the structural problem. This tooth needs a crown, because the crack is uncontrollable there. And what's going to happen is that you've done the root canal for symptoms. Yes, you've restored it, but you've done nothing for the crack, meaning the patient's going to chomp on that tooth again with the same force as prior to them having symptoms. You're going to end up with a split tooth. So that's like a different scenario there. Anterior teeth, for the most part, again, we need to go back and see, why do these present in the practice? So for example, you guys are more likely to see the anterior teeth that have got caries. Yes. And they're going to need root canals afterwards. Again, assess how much tooth structure is gone from the tooth before you start shaving it down for a crown. For me, I'm more likely to see those anterior teeth that have undergone trauma, or they're redos of a prior trauma treatment that's failing as time has moved on. So we need to ask ourselves again, if someone just had a simple concussive injury and the tooth ended up going necrotic, and it's just a simple incisal lingual access that I do to go in, shaving this tooth down for a crown may not provide any benefit whatsoever. However, the likelihood that this tooth had a microfracture initiated from the trauma event, and that's why it died, is also pretty high as well. So we need to make our judgments accordingly as well. One of the biggest technical challenges is lower anteriors. And for the most part, we never see caries on these, perhaps because the tongue is always brushing up against them. So meaning when we do treat these are trauma teeth. Now, shave these down for a crown, there's nothing left. Yeah. It's a peg. It's a peg.
Yeah.
And you've got to wonder that, if this patient's going to continue using this tooth, are they going to snap it at the gum line as well? So yes, we've got to be diligent in terms of how we do it. The other thing is also the choice of material as well. And then today, everybody's moving to zirconia crowns. Now, the color that we put into zirconia is much better than when we had monolithic. So it's much better nowadays. And, we can mill these a little bit thinner. We can prep these thinner as well. One of the issues with zirconia is that it's too damn hard. And it's so tough that for a patient who's got a grinding habit, it might be a bad choice for the opposing tooth.
Okay.
So I'm still old-fashioned, where if someone presents with a lower 3.7 or 4.7 with a cracked tooth, I would prefer them to put a gold crown. But the thing is, no one wants that anymore because of the color. Yeah. But the thing with the gold crown as well, at the same time, the prep is minimal. It's forgiving, it's malleable and ductile at the same time, so you don't have to worry about the opposing tooth, especially if the patient has tooth fracture related episode that's needing a root canal. So the choice of materials as well. And I find that most of the choice of materials, what we do, not just for restorative dentistry and for prosthodontics, and even for endodontics, is more based upon what sells, what people are doing as a consensus as well, versus actually selecting a material that's right for this patient. And this also comes in with the battle between amalgams and resins. Do I think amalgam is still one of the greatest materials out there? Absolutely. In certain cases, amalgams shine. One of the issues is that we say that amalgam causes cracks. Again, we need to look at the language here. Amalgam doesn't cause cracks. Amalgam's associated with cracks because these preps are GB Black principles from way back in the day.
Yes.
For prevention. The teeth may have been drilled on multiple times as well. Amalgam just sits there. The teeth the cusps are thinned out, but it's been in the mouth for like 35, 40 years, and now we have a crack-related episode. It's
Yes.
the same thing as saying that, resins cause secondary decay. No, resins are more associated with secondary caries because mainly poor isolation techniques to place them. So, there's definitely, I think resins are absolutely great, but I do think that, for dentists, we should still keep all the materials that have, proven longevity in dentistry and select them individually for the patient or that tooth in the patient's mouth that needs it. I think this one-trick pony that we're trying to do, and especially with endo as well, we're trying to simplify things too much. Just adds to more problems because we're not getting our colleagues to think about these and think about the processes in terms of what we're doing. We're just more having a consensus statement in terms of this is what you should do.
Yes.
And that's the issue in endo because, endo, for example, if you just take sealers, right? So I've been using H plus sealer for 15 years or so, and I have no desire to change. But then nowadays, as time has moved on, people are talking about using BC sealers, and we're talking. They're saying things like BC sealers increase healing potential, things like that. They don't. They don't at all. The healing potential is a function of not just your work, but the patient as well. But way back, if we go back, it's a function of the diagnosis. You can fill a root canal with no sealer and just gutta percha, and if you got everything dead on, it will heal. So it's getting on this bandwagon that really doesn't have any evidence whatsoever, and it's simply just to sell products, which is a shame because we're not ultimately serving the patient. We're more fueling the dental society, and the more we buy these products, the more they are then advertised out there as being the answer to everything, which they're not.
Yeah. Thank you so much for sharing all of your wisdom, Viraj.
Oh, no problem.
How can we reach you? What's the
Uh,
best way?
so you guys can just go on my Instagram at Virajendo, and then anybody can just message me there. I get tons of messages, so I will reply to you, and just ask me, whatever you want. And like I said, the whole thing's a journey. I've been an endodontist now coming like 14 years and 20 years as a dentist. I can tell you, there's still patients that come in, and there are still the odd ones that make me scratch my head as well at the same time. The best thing that you can do is just try to follow up with your patients, and follow up not just because you want to see how your work's doing. Patients appreciate a lot. They do. And especially, sometimes, when my staff calls, especially a 5, 6, 7 year follow-up, they don't even remember they came. But if they do make it in, then they're really, really like happy for the fact that we followed up with them. And those kind of connections that you make with the patient are absolutely priceless.
Yeah, that's it's not just about making patient connections, which is really important, and they improving the experience, but it's also to evaluate us. Like we need to grow
Exactly.
and see what works and what doesn't, and so
Exactly.
that we can get
Exactly.
patient outcomes.
Exactly. And,
Yeah.
and you know what? You want to know, what are you learning from your cases overall?
Yes.
As time moved on, what are you learning? And the main question is, are you even learning? That's the question.
Yeah.
Do you think you're actually learning? That's the thing. And just because cases become much more easier as time moves on, the technical aspect still might not mean you're learning. Meaning, I've said this many times before, if you get a very good carpenter, and they have very good hand to eye coordination and they have that inherent dexterity in them, I can teach them how to do root canals. They could probably do it much better than me. The biological aspect is going to be a problem, and the thinking factor as well, because they haven't gone through dental school. That's the part that we need to concentrate on as we grow. But from repetitious processes of doing the same procedure over and over again, you're going to get good at it.
Yeah. Well, thank you very much, Viraj.
Oh,
So
no problem.
follow Viraj at Viraj Endo at Instagram and keep learning. Thanks for helping us learn today, Viraj.
No problem,
Appreciate
Sally.
you being on the pod.
Thank you very much for having me.
Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.